Yeah. Thank you. So, Dr. Sham, you can take the lead.
Hello, good morning to all. On behalf of Indian Academy of Pediatric Delhi State, warm welcome to all our seniors member as well as our participant. And today we have the glad our chairperson is Dr. Aarti Maria and Sunil Mendirata sir, and our speaker is legend of the pediatric cardiology, Dr. ANITA SAXENA madam. So I would like to over to our president say the few words, then we can start the session.
So, good morning, everybody. I'm Dr. Pankaj Garg, President of Indian Academy of Pediatrics Delhi branch, and we are at the IAP Delhi platform, and we are doing academic activity throughout the year, and especially this e-master class, which has been a regular feature. Every Sunday, 9 o'clock for 1 hour, we dedicate to teaching, and then we can enjoy our day with our families. We have done a lot of master classes before. We have done on pediatric hematology, endocrinology, neonatology, rheumatology, and now is cardiology. And to those who are new to this platform, as Dr. Aarti and Dr. Anita, this is a paid program. And despite being a paid program, we have been having very good participation in a lot of sessions before. We have participation which has reached to 700 people also. So I think if you are regular, if the program is good, people are ready to pay and they're able to attend also. At the end of each session, we also conduct some MCQ based examination and then we give certificates. The next in line is the office-based pediatrics and residents guide on pediatric intensive care practices. So that will be starting. This is the 10th session of pediatric cardiology. So after this, two more, and then we will be starting the pediatric cardiology. So it's my pleasant duty to welcome Dr. Anita Saxena, who's the doyen of pediatric cardiology. We have all looked forward to her in case of pediatric cardiology issues. And Dr. Aarti Maria, she is such a senior person who has joined us as a chairperson, and we'll be waiting for Dr. Sunil also. So I'll hand over to Dr. Neeraj Agarwal, Dr. Mridul Agarwal. They are the ones who have really made this program interesting and such entertaining that everybody likes to join and also is very educated about it. So over to Dr. Neeraj for the proceedings. Dr.
So,
Neeraj.
good morning, everyone. Today is the 10th session, and I'm extremely grateful to have our chairperson, Dr. Aarti Maria ma'am. She's the Dean and Professor, ABVMS College and RML Hospital. She is a DM neonatologist and a high interest in neonatology. She has 3 decades of expertise in neonatal health and family policy advocacy. She's pioneer of family-centered care model. She's key member of advisory boards, multiple advisory boards like Small and Sick Newborns, UNICEF, WHO boards. She's authored review articles and papers in Lancet also. And I keep meeting ma'am in meetings, and she's extremely helpful and a good teacher. Welcome, Dr. Aarti Maria ma'am. And a few words from you to start the session, ma'am. Ma'am, you are muted, ma'am, possibly.
Thank you very much, Dr. Neeraj. And I really appreciate the efforts that Delhi branch of Indian Academy of Pediatrics is taking, all the strides that you're making in, education and academics, promoting academics. So really appreciate those efforts. And it's my most pleasant duty today morning to introduce none other than Dr. Professor Anita Saxena, who personally has been an inspiration for me and has been guiding me, has been helping me with whenever we were stuck clinically. And even today, when today means even these days when she was not even in AIMS, I have been bothering her many times and it was always helpful. So thank you, ma'am. And she is currently the Executive Director, Pediatric Cardiology and Head of Non-Invasive Cardiology at Fortis Escorts Heart Institute, New Delhi. She is Emeritus Professor, All India Institute of Medical Sciences, and she has also been the former Vice Chancellor, University of Health Sciences, Rohtak, former Dean Academics, Chief Cardiothoracic Center and Head of Department of Cardiology at AIMS, New Delhi. A great welcome and good morning to everybody and great welcome to ma'am. And I would hope ma'am will start the session without any further delay. And thank you very much for giving me this opportunity. Over to you, ma'am.
Thanks very much, Dr. Aarti, for those wonderful words. And thank you for all the discussion that we have about our patients. I think ultimately that's what we are here for. thanks to IAP for having this whole masterclass in cardiology. I think it's a much needed one. And I think Dr. Neeraj, Dr. Pankaj, Dr. Shyam, I think you all need a big congratulations for having it in your curriculum. So the task that has been given to me is how, when should we intervene and in whom should we intervene? I think this is really very, very important, because just because something is available doesn't mean that we should go ahead and do an intervention. I think a lot of unwarranted interventions are also to be avoided, and that's something I would like to give a message to all my younger colleagues, pediatricians, pediatric cardiology, that you don't have to refer any and everybody to cardiologist. I think you can take a decision as to when and how we should intervene. So I hope my slides are visible.
Yes, ma'am, they are visible, ma'am.
Okay. So as I said, this is the topic we're going to talk about. And before I, dwell on the individual lesions, I just would want everybody to know, I'm sure most of you would know, that we have published these guidelines in 2019, which are basically consensus guidelines, where we have, talked about each and individual lesion, where the timing and the indications have been very, very detailed. This has been published in Annals of Pediatric Cardiology, and this has been published in Indian Pediatrics, with a bit of modification, and of course Indian Heart Journal. So this is not just cardiology guidelines. I think these are guidelines for each and every practicing pediatrician as to when should we intervene in a particular heart disease or congenital heart disease. So just to set the tone, I would say that you should only intervene, or you should only go for any intervention, whether it is medical intervention, whether it is catheter intervention, or it is surgical intervention, only if you are sure that the intervention that you're going to do is going to benefit the patient rather than giving the risk. A classical example is of Epstein's anomaly. Epstein's anomaly or a small VSD, we know that these things can remain stable over a long period of time. As far as Epstein's is concerned, we don't even have a corrective procedure for Epstein. So we would only like to operate on Epstein when the patient is either symptomatic or desaturated. There has to be an indication, because we know that the risk of therapeutic intervention, be it surgery, is not zero. And also we know that the patient may not be completely cured or palliated based on the intervention. So I think it's very important that we ask these questions. What is the natural history of that lesion? What is the benefit of intervention? And what is the risk of intervention? If the natural history is better than the procedural outcome, for example, classical example being small ventricular septal defect, do nothing. Especially if results after surgery intervention is better, yes, do something. For example, you have a small VSD with aortic regurgitation. Yes, it is always good to go for intervention in such patient, which is surgery, simply because aortic valve damage can be arrested, or even aortic valve can be repaired if it is damaged. So now just common congenital heart diseases is what I'm going to talk about. And this is how we usually classify. I think everybody is familiar with it. Left to right shunt, obstructive lesions, and of the cyanotic lesions, we talk of tetralogy or like tetralogy conditions. And then one group is of increased pulmonary blood flow, where you tend to have much more sicker babies who need rather early intervention. So let's go to left to right shunts. The classical example is ASD, although we don't see ASD at birth, or patients are not symptomatic usually, but it is becoming pretty common to have ASDs being diagnosed on echocardiography, because echo has become so prevalent that you will have a baby, maybe a month old or even a newborn, walking in with an echo report, the parents bringing the baby with an echo report, which says 3 millimeter, 4 millimeter, 5 millimeter ASD, and then you don't know what to do about it. So a lot will depend. Where is it located? What is the time at which the baby or the patient is presenting? Are there any symptoms? Is there any evidence of pulmonary arterial hypertension? Is the baby in trouble because of ASD, which is very rare? What is the natural history? We know that any ASD, diagnosed at birth, which is less than 8 millimeter, tends to close over time. So we don't have to intervene in such cases. And are there any comorbidities? So all hemodynamically significant ASDs. When I say hemodynamically significant ASDs, I mean an ASD which is producing right ventricular volume overload. That means right atrium and right ventricle is dilated. All such ASDs, yes, do require closure, unless, of course, we are dealing with an Eisenmenger syndrome, which is something you are not going to see much in the pediatric age. Maybe in 40s and 50s, you may have pulmonary artery hypertension. So all these ASDs need to be closed. What is the time? In a stable child who's presenting to you early, you could wait for 2-3 years or even 4 years for ASD closure, especially because now we have devices for closing the ASD, which we don't want to do in very small babies because of obviously the risks are higher. But if it is a ASD which is located in the sinus venosus region, that means in a very high level over here, which is very close to the superior vena cava and right upper pulmonary vein, then you may want to wait for a little longer for baby to be over 10-12 kilogram, because operating on such sinus venosus ASDs can result in superior vena cava obstruction rarely. If you have a baby who's symptomatic and you are very sure that this symptom is because of ASD, which does happen in about 5% of infants, you may want to go for early closure. Of course, you need to rule out all the associated lesions. If the patient presents later, let's say 10 years, 11 years, because it's not uncommon, even 50 years ASDs presenting because they've been just incidentally diagnosed, they were asymptomatic all along. Again, you need to see if there is significant left to right shunt, which means there is right ventricular volume overload. We should go for elective closure at whatever age they present, because there is data to say that such patients do better after closure than if they are left alone with an ASD. However, if there is PAH, again, you have to be a little cautious. And of course, rarely we have children who have, come with stroke, and those are the cases of patent foramen ovale. Again, there is not very robust data to say that these closure of these PFOs is going to help them. But yes, a lot of us do that simply if we think that stroke has happened because of paradoxical emboli. And of course, you have to do various tests to make sure that you are doing the right thing. And this is really responsible for stroke in a child. But yes, all stroke children should get investigated for any patent foramen ovale. Patent foramen ovale is a very common finding. If we do echo in 100 people, we are going to see in 25. That means every fourth patient is going to have a patent foramen ovale. So that doesn't become an indication for closure. Established mode for a very many decades has been surgery. Go for surgery. However, if you have a very central nice fossa ovalis ASD, which is right in the middle of the atrial septum, and you have enough rims, as we call them, all around it, then device closure is something that we like to do. Being a non-surgical procedure, patient obviously recovers much faster. And of course, there is no scar, there is no complication in terms of open heart surgery. So therefore, device closure has become the norm these days, unless of course the ASD is in the unusual location like primum ASD or an ASD in the sinus venosus area. Otherwise, we would go for a device closure. And we have multiple devices now which can be used for closing these ASDs. Now, coming to ventricular septal defect, again, you can have perimembranous, which is the commonest VSD that we see, but it could be below the pulmonary valve, it could be muscular. In fact, muscular VSDs are again quite common at birth. They are generally small and they tend to close. So again, we need to see at what age the patient is presenting, what is the size of the defect, how is the pulmonary artery pressure. And that is really easy to understand, because when there is a VSD, you are likely to get a gradient between LV, left ventricle and right ventricle, because if the VSD is very small and restrictive. However, if it is a large VSD, the gradient will be abolished. Right ventricular pressure will be same as left ventricular pressure, and therefore there has to be severe pulmonary arterial hypertension. So where is it located? Are there any symptoms because of the VSD? And we know that large VSDs do produce heart failure right soon after birth, maybe a couple of weeks after birth, and not uncommon to have these children having recurrent LRTIs, again and again presenting with failure to thrive, feeding difficulties and all that. So obviously that indicates a large VSD. But moderate VSDs and small VSDs tend to become smaller, although large VSDs perhaps stay large, very rarely they close. But again, small VSDs, you just have to wait and watch. And of course, if there are any comorbidities. So looking at the natural history of VSD, which is very important, I think if the VSD is not very large to begin with, the spontaneous reduction in size and even closure have been described, especially for muscular VSDs. Muscular VSDs tend to close much more than, let's say, perimembranous VSDs. Outlet VSDs or subpulmonic VSDs hardly ever close. So we need to know what is happening to the VSD over a period of time. Of course, if the baby is in cardiac failure, if baby is having all the features of, heart failure, then you have no choice but to go for early surgery. Otherwise, the baby will succumb. When we follow them up for a longer period of time, let's say around 3-4 years or 5 years, some of them may develop aortic regurgitation, about 5%. This is common with perimembranous VSD as well as subpulmonic VSD. Sometimes you may have left ventricular outflow tract obstruction, much rarer, or arrhythmias. But what we are most dreaded about, what we are most scared about is Eisenmenger syndrome or developing pulmonary vascular obstructive disease. And that is one reason why a large VSD should not be left alone, because it is well described that if you operate on them later, then pulmonary artery pressures may not return to normal. And therefore, this is something we need to avoid. Something that we do not see much in ASD, but yes, we do see in large VSD and large PDA. Then, of course, rarely they may develop pulmonary stenosis. We call it Gasul phenomena. And of course, this is a complication that tends to happen more with smaller VSDs rather than big VSDs. So I'll show you two cases. This is a 4-month-old child who's got history very typical of a large VSD with sucrase subcycle, recurrent LRGIs, tachypnea, feeding difficulties, and so on. And you have a 10-month-old child who's asymptomatic. Just a murmur has been discovered. Mother denies any history of tachypnea or sucrase cycle or diaphoresis or feeding difficulties and has been thriving well. So the 4-month-old child is only 4 kilograms. So he is quite undernourished. He has features of heart failure, tachypnea, tachycardia, hepatomegaly. There is prominent pulsations over the precordium suggesting cardiomegaly. And there is a short murmur. You can see there is just grade 2/6 early systolic murmur with a loud P2. And we also often hear an MDM at the apex, mid-diastolic murmur, which is because of the extra flow that occurs across the mitral valve. On the other hand, this child, who's also not too good in weight, but has no features of heart failure, he does have mild cardiomegaly, and he has a good pan-systolic murmur, grade 3/6. So this is very, very important. The length of the murmur, the loudness of the murmur can give you an idea as to the size of shunt that is happening across the VSD. And he also has a third heart sound, which means that his left to right shunt is not very small. That third heart sound at apex would also mean that the left to right shunt may be around 2:1 or 1.5 to 2:1. So it's like a moderate VSD. This is the X-ray of the 4-month-old child, huge cardiomegaly, increased pulmonary vascularity, ECG showing biventricular hypertrophy with good left ventricular forces. And this is the X-ray of that moderate VSD 10-month-old child. Now, the small baby obviously cannot wait, needs surgery. He is in heart failure. He has cardiomegaly. We know his pulmonary artery pressures are equal to systemic pressure. On the other hand, the one with moderate VSD, he's only 10 months old. He can wait because his VA pressure is likely to be less than half systemic. So he can wait. Not that he will not require, he may also require surgery, but you don't have to rush into surgery because there is a possibility that this VSD may come down in size, and the chances of VSDs coming down in size and even closing are highest in the first 3 years of life. They don't become zero, but yes, the chances get less and less as the baby becomes older. Generally, after 5 years, it doesn't really change much. And therefore, if you have waited up to 3 years or 4 years and you find that the VSD is still not getting very small, you will have to go and close it. So this is the large VSD echo. You can see a large perimembranous VSD here with a color which is not showing any turbulence, suggesting that there is equal pressure between RV and LV. This is another patient that you've been following where you thought it was a moderate VSD, but the VSD is now getting smaller. And this is happening because of the right coronary cusp prolapse. So even a small or a moderate VSD needs to be followed up, knowing very well that this VSD may become smaller, but one of the mechanism of VSD getting smaller is prolapse of right coronary cusp, which obviously you cannot make out clinically or by X-ray or ECG. It has to be an echo. And if you find that there is some amount of aortic regurgitation, so even if the VSD is small, any amount of aortic regurgitation would indicate its closure, because at this point of time, you could perhaps get away without replacing the aortic valve, something that we don't want to do ever, especially in children. So therefore, closing this VSD may arrest this AR right here or may even improve it, because there is a right coronary cusp prolapse which can be sort of pulled by the surgeon at the time of VSD closure. and the AR may become even less or may disappear. So a small VSD has certain indications where you will have to intervene. And let's see what those indications are. Small VSD, no symptoms, normal pulmonary artery pressure, no left ventricular volume overload. Very simple, just follow them up. You have to avoid infective endocarditis, and if you find AR on follow-up, then it will become an indication for surgery. Simple AR in the presence of VSD will be an indication for surgery. In fact, usually patients who have AR have a smaller VSD because it is the right coronary cusp which keeps prolapsing and closing the VSD. That is the mechanism of reduction in size. If you have a moderate VSD, again, the pulmonary artery pressures tend to be normal or mildly elevated, but there is evidence of left ventricular volume overload on echo. There may be mild cardiomegaly on X-ray. If the child is asymptomatic, you could wait for some more time, closely following up such children. However, if you realize that it is not getting any better, it is best to close such VSDs also. Now we have much less morbidity and mortality of open heart surgery. And of course, we do have devices also now. However, if this child is symptomatic, having some features of failure to thrive or mild heart failure, we put them on furosemide and we try to control. If it can be controlled, you can wait till 1 year or so. But if it cannot be controlled, better to go ahead and operate, provided you are convinced that symptoms are because of the VSD. In case of large VSD, high PA pressure, left ventricular volume overload. So I'm saying left ventricular volume overload, suggesting that this patient is still operable. So you try and control with medications and then close it. Now I've written 6 months, but I think a lot of us are closing or a lot of us are referring them at 4 to 6 months. However, if the patient is not improving despite medication, then best is to go ahead and operate even earlier than 3 months. Although that doesn't happen very frequently, most of the time you can wait till 3-4 months of age before sending them for surgery. So in older patients, this is what I have taken from European Society of Cardiology. And what it shows is that in older patient, what you're worried about is pulmonary arterial hypertension. Again, if there is AR, you operate the small VSD, you leave them alone. You don't have to worry about small VSDs with no volume overload. However, if there's a large VSD, then the issue of pulmonary vascular disease crops up, and such patients must be assessed, preferably by cardiac catheterization, to know what is their PVR. As long as PVR is less than 5 units and there is good amount of left to right flow of more than 1.5:1, one should go ahead and close. However, if the PVR is high, or if the flows are not very large, you may not want to close these patients. And in fact, these are the patients who might be developing Eisenmenger syndrome. Cardiac cath, of course, is necessary, and we also do vasodilator testing in the lab. VSD with significant pulmonary vascular obstructive disease, just don't go by the cath data. It has to be a careful decision based on clinical examination, X-ray, ECG, before we decide whether to operate or not. And again, I think I have said it many a times, in case of doubt, when you have a high PVRI, when you are not very sure, it may be better not to operate rather than operate on them. What are the methods of closure? Conventional surgery, you close by putting a patch or sometimes even direct closure. That is the conventional method. And as I said, the mortality has become negligible. Morbidity is very low. Even 3-4 kilo babies are being operated without any significant problems in the post-op period. Pulmonary artery bending has very limited indications, especially now that open heart surgery has become much safer for smaller babies also. But yes, if the VSDs are too many, you may have to resort to pulmonary artery bending, especially in small children, because we know it is difficult to close all these VSDs. Sometimes you are stuck with somebody having a pneumonia, which is not just getting better. Patient is being complicated because of heart failure. You may have to request your surgeon to go for banding at the moment, and then of course later do debanding and close the VSD. But what is come up now is device closure. I think many of the cardiologists are closing VSDs which are located in appropriate location by devices. And when I say appropriate, I mean that it should not be close to any valve. Especially, we are worried about aortic valve. If VSD is close to aortic valve, we don't close it by device. But if it is little away from aortic valve, one can think about closing by a device. Again, large VSDs, especially small children, may not be suited for a device closure. because device closure obviously needs bigger sheaths, bigger heart to take care of, and therefore probably in infants it's still something that we avoid. This is the eligible criteria for device closure. As I said, weight has to be more than 8 kilograms, has to be a large shunt, and I think it is best done for muscular VSDs because you have all the rims around the VSD. In perimembranous VSD, you have to be careful that you are away from aortic valve. The only complication that may happen because of device closure is aortic regurgitation. Because if you are very close to aortic valve, it can produce aortic regurgitation, and in some cases you may end up developing conduction defects, because remember the conduction bundle is sitting right near perimembranous region, and we know that during surgery also sometimes these babies can get complete heart block. So one has to be mindful of these complications. And of course, there are some contraindications that one has to see. So, but still, I think for a small percentage of patients, device closure of VSD is possible and is a good method because it is non-surgical. Atrioventricular septal defect associated often with Down syndrome. We know 50% of Down syndrome babies will have a congenital heart disease, and AVSD is the commonest. And large VSD, large ASD as a component of AVSD, which is called complete AVSD, it is best to close them as early as possible. They may be associated aortic atrioventricular valve regurgitation, often because of cleft in the mitral valve. Surgery for Down syndrome patients has to be even earlier because they tend to develop very high pulmonary vascular resistance rather early compared to a non-Down syndrome. Ductus arteriosus is simple. All ductuses must be closed. Small or large, they all need to be closed as long as PVR is not very high, which is not usually a case under 1 year of age. However, a simple PDA diagnosed on echocardiography without a murmur, as we call it silent PDA, it is not recommended to close such silent PDAs. So if you have somebody coming in with an echo report which says that there is a PDA or a small PDA, I think best is to auscultate that child in a quiet room. And if you find no murmur, not even systolic, good systolic, or a continuous murmur, then these patients are best, or these children are best left alone and need not be closed. But as I said, if there is severe pulmonary artery hypertension beyond 6 to 9 months, they must undergo assessment for operability. We generally believe that PDA is Eisenmengerize earlier than VSD. Therefore, generally the age that we talk about is about 2 years for a VSD. By 2 years, they may start to develop significant pulmonary vascular disease, and it may not be possible to operate on them. In case of PDA, that age may be 9 months or even 10 months or 1 year. So therefore, PDAs, one has to be even more careful when they are large and having severe pulmonary arterial hypertension. Again, conventional method, surgical ligation. However, now we have practically all PDAs are being dealt with transcatheter closure device. Sometimes we use coils, etc. We used to, in fact, devices have become much more user-friendly now. So we close all the PDAs with device. As long as we know the PDA is operable and PDA is not silent, we should close it with the device. And I think as pediatrician, you know it better that we could use one of these drugs to close PDAs in a preterm babies. Of course, they have no value in term babies. So as far as preterm babies are concerned, I think I'm not going to talk about it because you all know it better. And I think we are now moving more towards not closing them by surgery or piccolo than we used to, because we believe that PDAs are not so important in overall morbidity of these babies. Now, coming to obstructive lesion, and I would talk about coarctation first, because coarctation is something that is often missed. And unless we feel for the femoral pulses, we are not going to diagnose, especially because in children, we don't even measure blood pressure often. I think in most of us in our pediatric practice have not been measuring BP as a routine, despite the recommendation from various bodies that you should measure BP in those who are 3 years or more. But because we don't measure it, we often miss it, unless, of course, the baby presents in the neonatal period with left ventricular dysfunction, or it has been diagnosed soon after birth, or sometimes even antenatally, it is suspected that this baby might develop coarctation of aorta. But the indications are if the gradient is more than 20, unless, of course, there is LV dysfunction. If there is LV dysfunction, any gradient is significant. Those who have upper limb hypertension also need to be treated for coarctation of aorta. And of course, we go sometimes by echo, by angio, and often we end up doing other imagings like CT angiography, cardiac MRI, etc., to know what the anatomy is, because in older children, anatomy may not be very well seen on echocardiography. Yes, it is very clear in children or in infants, but in older children, it may be an issue. So what do we do? How do we treat them? If it is neonatal presentation, we should go for surgery. In fact, under 3 months, if the baby is presenting before 3 months, surgery is a preferable option to balloon dilatation. But at times, you may have a critically ill neonate who may have a high blood urea, high creatinine, is in shock, left ventricle is too bad, surgeon feels that it is a high risk case, so you may just do the balloon angioplasty to tide over the crisis, knowing very well that this coact is going to come back. So you give them little time, like a bridge, so that they recover, and then as soon as they show coact again, you send them for surgery. So recoactation or restenosis is very common if you balloon them in neonatal period. Having said that, even surgery can result in recoactation in many of these neonates, but still the chances of recoact is more with balloon than with surgery in infants under 3 months of age. Those who are little older, you can surely go for balloon angioplasty. If the child is more than 10 years or more than 25 kilograms, then we can even go and put a stent in the coarctation, so that recoarctation does not happen, so that recoil does not happen. So often we put a stent. If the child has had surgery and is now coming well with coarctation, then balloon dilatation is the best option, and we should avoid sending such patients for surgery. Covered stent is a stent which is covered with some kind of a material so that there is no flow happening, unlike bare metal stent where flow can happen through the struts. So covered stent is something that we often not use. We only use in certain conditions where you feel that the coact may end up, a coact dilatation may end up with a complication like rupture of aorta, for example, in Turner syndrome, in very old patients. If it is very, very tight coact, and those are the cases where you should keep a covered stent handy, so that if you get into any complication, you are able to use a covered stent. I think aortic stenosis is now becoming almost, in children, we are talking about balloon dilatation. Very often we are going for balloon dilatation, although there is some data that is coming that in neonates, surgery may be better than balloon dilatation. But I think in practice, we are all ballooning these children whenever they're coming with severe aortic stenosis. And when I say severe aortic stenosis, we mean a peak to peak gradient of 64 or a mean gradient of more than 40. Such patients should undergo aortic valve balloon dilatation. Again, the parents should understand that it is a palliative procedure. The child needs follow-up, and child may need an aortic valve replacement when maybe, when he's bigger, more than 20 years or 18 years. And before that, if restenosis happens, you can redilate them. Again, do not intervene in an asymptomatic child who has a normal ECG, an AS gradient of less than 40 mean or less than 64 peak. So I think we need to be careful when not to intervene. These patients or these children are best followed up rather than intervene, because we know it's a palliative procedure. You are likely to intervene again and again, so better to do it at the right time for the first time. Pulmonary stenosis, again, we are a little more liberal. Any gradient more than 50 nowadays, we say, okay, we go ahead and balloon them. And the good thing is that in case of pulmonary stenosis, balloon may be the final, you do one ballooning or maybe another one if required, but generally they don't require any surgery. In majority of cases, you can get away by simple balloon dilatation. Indications are same, but if there is right ventricular dysfunction, which is sometimes the case in neonates and infants, then you may have to do it immediately. Immediate intervention may be required. Now, coming to cyanotic heart disease, I will start with this case, which is something that we all see in our practice. 6-month-old, full term, presenting with cyanosis from early infancy, which is increasing on crying, history of recurrent spells, but there is no history suggestive of heart failure, that is Sucrase cycle or feeding diaphoresis, etc., etc. This is the finding, saturation of 72%, no cardiomegaly, as you can see, and single second heart sound with a grade 3 ejection systolic murmur in the pulmonary area, X-ray showing absence of cardiomegaly with pulmonary oligemia, and there is some suggestion of pulmonary bay, as you can see over here. What is the possible diagnosis and how will you manage? I think it is very likely that we are dealing with the patient of tetralogy of Fallot's or one of its variant, and we know that the cyanosis is because of mixing at the VSD level and reduction in the pulmonary blood flow due to pulmonary stenosis. ECG showing northwest axis with significant right ventricular hypertrophy, not really typical of tetralogy because you have rather late transition in V3. In tetralogy, we tend to have early transition and the axis is going too much to the right. Maybe we are dealing with double outlet right ventricle PS, which is nothing but a variant of tetralogy. This is the echo showing a large subaortic VSD. This is aorta. This is left ventricle, right ventricle, interventricular septum. And this is what you're getting, severe pulmonary stenosis gradients of more than 64 millimeters of mercury. So this is again pretty classical of tetralogy of Fallot's. So you may have little variation in ECG and X-ray, but still tetralogy is the commonest cyanotic heart disease, especially if you are dealing with a child who's more than 1 year of age, because their survival is better than other cyanotic heart diseases. Now, all patients need surgical repair, even if they are pink tetralogy of Fallot's. They all need to be treated, and the current mode of treatment is surgery. Yes, till they undergo surgery, we can stabilize them by maintaining their good hemoglobin, especially if they are very blue, maintain their hemoglobin more than 14. You may have to give them blood transfusion, give them beta blockers in the highest tolerated doses. And if it is a neonate presenting with severe cyanosis, you may have to give them prostaglandin infusion to tide over the crisis. If the child is minimally cyanosed, stable, one can go ahead and do total repair at 6 months. Some people say 7 kilograms of weight. So it really varies from institution to institution, but most of the good institutions would like to completely correct them by about 6 months to 9 months of age. However, if the patient is symptomatic significantly before that, has significant cyanosis or histiospell, then you may have to resort to palliation, but a lot of institutions are again going for total correction rather than palliation. If it is a newborn, you could even do a stenting of the right ventricular outflow tract. If it is, you could also ask your surgeon to do a BT shunt, or we call it BTT shunt these days. And of course, ultimately it has to be correction. Then there are certain variants like tetralogy of Fallot's with absent pulmonary valve, where you have a lot of pulmonary regurgitation. These are the patients who have very huge branch pulmonary arteries, that is right and left pulmonary arteries. And these are the patients who may present with pneumonias because they have some inadequacy of their respiratory system. These patients may be best operated around a year, where you can do a lot of pulmonary artery plasty because you want to reduce the size of branch pulmonary arteries, because these branch pulmonary arteries are aneurysmal and they may be pressing on the respiratory tree. If you have an anatomy which is not really suitable for total correction, for example, there is a left anterior descending artery which is coming from right coronary artery, which is seen in about 3 to 5% of tetralogies, and these are the children who will actually need a conduit to ensure that left anterior descending artery doesn't get damaged while putting a transannular patch. These patients may again be best left for some time, and if they need something to be done, they could probably have a shunt rather than a total correction. Yes, little bigger children, more than a year or so, one could go ahead and do a conduit repair, which will take care of this LAD problem also, because you are not giving them a transannular patch. Pulmonary atresia is a bit more complex because there are variations in the anatomy of pulmonary atresia depending upon the size, depending upon whether they are present or not present, whether they are being supplied by collateral. So one has to really define it well. And this is one case where you may end up doing a cardiac catheterization, MRI, CT, something to let your surgeon know the whole anatomy of pulmonary tree. But if a baby is presenting soon after birth, as the PDA is closing, best is to put them on PGE infusion. And on a longer term, depending upon the anatomy, you may either go for a PDA stenting or a BT shunt, whatever you are comfortable, whatever your surgeon. But best is to have discussion with your surgeon before deciding the mode of therapy. If there are good pulmonary arteries, yes, go ahead and operate. I think 3 to 4 years may be too late. You may want to operate at 2 years also, because all these children are going to require a conduit. But obviously, this is for straightforward cases who have nice pulmonary arteries like the first one, like this one, and not for these. I think these need a lot of staged repair and not just one-time repair. Stenting of PDA for pulmonary atresia is now becoming an alternate for modified BT shunt, because BT shunt has higher morbidity and mortality in soon after birth, and therefore it may be better to stent them. And I think most of us now are, sort of leaning towards stenting of PDA. You can see one case over here with the stenting of the patent ductus has been done, and that will obviously help them or help their pulmonary arteries to grow better. And of course, it being relatively less invasive procedure than BT shunt. I think there is a lot of data that is coming up, which is comparing the two modalities, and it has been found that BT shunt, stenting may be better in terms of immediate morbidity mortality, but the interventions or reinterventions rates may be higher with stenting compared to BT shunt. So I think this is a good alternative, and I would say at the moment they're equal as far as efficacy is concerned. Then there are certain TOF-like conditions where you can do repair like that of tetralogy. That means there is two ventricle which repair is possible. Again, we generally follow the scheme as we do for tetralogy. If they are minimally cyanosed, do it around 1 year, 2 year, wherever your surgeon is comfortable at whatever age and weight. But of course, if they're significantly blue, one may have to resort to BT shunt and then go for a repair later. Double outlet right ventricle is something that we often talk about, but what I wanted to show over here is that double outlet right ventricle has a spectrum. It depends where the VSD is located. I think that will define what kind of surgery or what kind of palliation we are going to do. If it is a subaortic VSD with pulmonary stenosis, which is very much like tetralogy, and we call it double outlet because more than 50% of aorta and pulmonary arteries are arising from right ventricle. That's a simple definition of DORV, that more than half of aorta, more than half of pulmonary arteries coming out of right ventricle. So you may have a situation where there is subaortic VSD. Again, treat them like tetralogy. They almost behave like tetralogy. Their management should be like tetralogy. On the other hand, you have another situation where the VSD is located below the pulmonary valve. And these are the patients who present more like transposition, because the VSD is located in a manner that the streaming happens in a transposition-like physiology. So these are the patients who may end up having a surgery which is similar to that of transposition of great arteries. Of course, you have to take care of the pulmonary stenosis part over here by somehow or the other. You may also have double outlet right ventricle without pulmonary stenosis. And again here, if it is subaortic VSD, it almost becomes like a VSD. So a large VSD and subaortic VSD in DORV have to be treated almost at par, and the surgery is possible. On the other hand, if you have a VSD in the subpulmonic location, then they have to be treated like transposition. And what we do is arterial switch operation, which I will just talk about when we talk about the TGA part. So DORV is a huge spectrum, and there are more variants which I have not included. For example, you may have a VSD which is non-committed, which is neither subaortic nor subpulmonic, lying remotely somewhere in the muscular VSD. If there is associated aortic arch anomaly, which is not uncommon with this variant, where you have TGA-like physiology with the pulmonary artery hypertension, then we should take care of the arch at the same time. And if the VSD is remote, that means not in any of these locations, you may have to think about giving up biventricular repair and going for a univentricular palliation. And so let's talk of transposition. I think TGA is, again, like DORV, has a huge spectrum, whether associated VSD or not. What is the location of VSD? But to begin with, we may have to give them prostaglandin infusion to keep the ductus open, and we may have to do balloon atrial septostomy in very hypoxemic babies, because when they are born, as soon as their ASD, as soon as their PDA closes, the ASD becomes smaller, they become extremely hypoxic, and unless something is done for them, they succumb. It is believed that if you don't intervene, 80% of TGAs will not see their first birthday. So it's a really malignant disease which requires almost urgent care. And of course, you keep the ductus open by prostaglandin, you create an ASD by balloon atrial septostomy. But ultimately, they need to have surgery. So if you have intact ventricular septum, we think an early surgery should be done, because their left ventricle is facing pulmonary artery, and as the baby grows, the pulmonary artery pressure goes down like in natural people, and therefore the left ventricle involutes, and you may not be able to do arterial switch later. So what we do in arterial switch, we just switch the pulmonary artery to the RV and switch the aorta to the LV, and of course take the coronary buttons to the aorta. So this is switch operation, arterial switch operation as we call it. But if patient has a VSD or a PDA, then the left ventricle remains prepared. But again, you don't want to delay it too much. Usually we like to do it at 2 weeks, 3 weeks, or as soon as the patient presents, but definitely by 3 months, because if we don't do by 3 months, these patients may develop severe pulmonary vascular disease. And of course, if you have PS, then we've already said you have to almost do it the way we do for DORV, subpulmonic VSD PS. But if VSD is remote, or if it is difficult to treat their pulmonary stenosis part, you may again end up having a univentricular repair. And when we say univentricular repair, which means that either you have one ventricle only, for example, tricuspid atresia or double-ended left ventricle, or the VSD is located in such a way that you can't close it. So these are the patients who would go for a univentricular repair. So we kind of club them together as univentricular heart, even if they have two ventricles. So what we do is, of course, initially you may do a shunt or band, whatever, but at about 4 months of age, we do a Glenn where we connect superior vena cava to the right pulmonary artery, putting all the blood from the upper part of the body into the pulmonary artery directly. And at a later stage, this is done around 4 to 6 months, and this is done around 2 years to 3 years or 4 years. You can put inferior vena cava also through a conduit, we call it extracardiac content, into the right pulmonary artery. Now, what is happening? The whole of venous blood is going into pulmonary artery without a ventricle. On the other hand, whatever ventricle is available, single or two or whatever, is being used for the systemic circulation. But remember, this is the ventricle which is pushing even this circulation indirectly. So there is one ventricle which is basically taking care of the whole circulation. Of course, if patient presents earlier than 4 months, you don't want to do a Glenn, you may do a BT shunt. Since it is a univentricular palliation, we must understand that the long-term outcomes are not like normal. I think parents need to understand, parents need to be told, counseled that they need to keep coming for follow-up, and there is a possibility that the child may require more and more intervention as time goes on. As of now, it is believed that their survival up to 30-35 is not uncommon, provided they have a very nice follow-up and all the morbidities taken care of. But any arrhythmia, ventricular dysfunction, AV valve regurgitation, all that really pushes them into fontaine failure, as we call it. And one needs to be very watchful of these complications. And therefore, a very meticulous follow-up is what is required. And the parents must be told that it is not something that we are doing it as correction, it is a palliation. So in univentricular hearts, if we have somebody walking in at less than 3 months, if there is pulmonary artery hypertension, we try and do a band to make their pulmonary artery pressures low. And if there is PN, then obviously pulmonary artery pressure is already low, but ultimately they end up for a Glenn and then of course a fontaine. It is very important to have low pulmonary artery pressure and low PVRI, otherwise the univentricular palliation will not work because there is no ventricle on the venous side. So we have to have low PA pressure. Remember, whatever the pressure is in the pulmonary artery, SVC pressure has to be same or higher for the blood to be propelled into the pulmonary circulation. And as I said, they would require additional procedures like AV valve repair, atrial septectomy, depending upon what all do they have at the time of Glenn or a fontaine procedure. Just briefly about TAPVC, again, a rather serious disease. All patients need surgical repair. Results are good. Patients who have obstruction would have severe pulmonary venous hypertension. They almost require an emergency surgery, whereas others will present in heart failure. They also need to be operated as soon as possible. Very unusually, you may get a case where there is severe pulmonary artery hypertension. The patient is presenting later in life. But if they present later in life, one has to be careful about pulmonary artery pressure and their operability status. Again, Truncus arteriosus is another disease, cyanotic with large pulmonary blood flow, needs to be treated. Everyone needs to be treated. But again, one needs to understand that there's going to be a conduit which will be placed from right ventricle to pulmonary artery. And therefore, again, these are the patients who would need repeated observation, repeated follow-up, unlike TAPVC, which usually get corrected. Abstinence anomaly, I think we see it all ages. We see it in children, we see it in adults, we see it even in elderly. And again, there are specific indications for surgery in abstinence anomaly. If the child or the patient is totally asymptomatic, saturation is good, I think we can leave them alone because the results are not necessarily very good. But of course, if there is cyanosis, if there is symptom, if there is cardiomegaly on the X-ray or right ventricle is showing a bit of dysfunction, it is best to send them for tricuspid valve repair, which again varies what kind of repair surgeon does, but cone repair is the one which is most often done. So I'm just going to summarize the cyanotic congenital heart disease part over here. If there is pulmonary stenosis, I think echo will tell us if the child is for univentricular or biventricular repair. If there is biventricular repair and a conduit is not required, classical example being tetralogy, go ahead and operate. Whether you do a shunt first or directly go for intracardiac repair is in institution policy, surgeon's decision. However, if conduit is required, you don't want to do it very early because conduit will require a change. So we like to wait, maybe do a shunt in the meantime, and then of course repair with a conduit. In case of univentricular repair, again, if the child is presenting very early, you may have to go for a shunt or a PDA stent. Sometimes if the child is presenting late, go for a Glenn straight away. And then ultimately patient has to go for a Fontan surgery, which is the final palliation for a univentricular repair, a univentricular heart. However, if patient is presenting with severe pulmonary arterial hypertension, if it is univentricular, then go for a band because you want pulmonary artery pressures to be low, and then of course Glenn and Fontan pathway. However, if it is biventricular, if presenting very early, they are likely to be operable and therefore go for corrective surgery, whether it is arterial switch surgery or a total anomalous pulmonary venous connection surgery or a Truncus surgery. Normal PA pressure in a cyanotic heart is only seen in abstinence anomaly, and as I said, there are specific indications for tricuspid valve repair in them. If there is severe pulmonary artery hypertension, and if you think that patient is inoperable, is getting into Eisenmenger, then of course we have to leave them alone because they could be inoperable, and operating on such children can be very dangerous. So the classical example of a biventricular repair with pulmonary stenosis tetralogy, DORV, conduit is pulmonary atresia VSD or sometimes TGA VSD PS because the VSD is in a location where you have to put a conduit for RV to PA. Fontan surgery for all univentricular hearts, severe PH, arterial switch operation for TGA, TAPVC, Truncus. So I think I'm just going to end with 3 slides. What are the timing of intervention? Elective surgery for AST, VST, PDA, coarctation, tetralogy, univentricular heart with PS who are not spelling. Obviously, if they're spelling, then it has to be early surgery. Early intervention for patients who are symptomatic, whether there is recurrent LRTIs, if you have a large VSD with recurrent LRTIs, congestive heart failure, ventricular dysfunction, severe pulmonary arterial hypertension, severe cyanosis, and pulmonary venous hypertension, they require early intervention. Some of the conditions require emergency intervention, like obstructive total anomalous pulmonary venous connection, critical obstructive lesions, especially those associated with ventricular dysfunction, severe coarctation with LV dysfunction seen sometimes in neonate, or if there is persistent cyanotic spell and a patient having TGA with intact ventricular septum who is very, very blue. So there you have to immediately intervene in terms of balloon atrial septostomy. So thank you very much. I would just like to end by letting let me stop sharing, letting the audience know that we are holding a echo in congenital heart disease, basics of echo in congenital heart disease session on 9th and 10th of August. If you are interested, you can contact me or you can contact Dr. Neeraj Agarwal.
Yeah,
and we will register you for this workshop, which is on 9th and 10th of August at Fortis Heart Institute. Thank you again for your patient listening.
Thank you, ma'am. Neeraj, can I come in?
Yes, ma'am. Sure.
Yeah, Dr. ANITA.
Yeah. So, ma'am, it was a treat, really, an academic treat to hear you. And I'm sorry, my video is not visible. However, I've been listening intently. And ma'am, it was you make things so simple. I think the best teacher is one who can make the complex things simple. You have a fantastic art of it. It speaks of your years and years of your experience and clinical wisdom. So I think there was so much to learn and recapitulate. And I was reliving those cases and times when we were stuck up and we really understand. And I think times have come when we have become siloed into various super specialities, subspecialties. But I think the basics remain. And if we actually learn these, because knowledge is empowering. So I think if all pediatricians are familiar with these basic rules and concepts and principles, I think we will be able to synchronize and manage our children and babies much better. And we then know not to overburden the cardiologist, and a lot of things, as you said in the beginning, when not to intervene, those decisions at least can be clearly taken. And when there is doubt, of course, you people are there to rescue us. So it was great, amazing, and thank you so much, ma'am. It was great to hear you.
Thank you.
Thank you. Over.
Thank you.
ma'am.
Thank you.
Dr. Mridul, there are some questions on the panel. Mridul?
I think one is about the weight criteria for TAPV, obstructive TAPVC. I just want to let everybody know weight is no more a criteria for anything. I think we have had patients of 1.5 kilogram, 1.8 kilogram who've had not just surgery, PDS stenting, all kinds of interventions. So I think weight, with thanks to the pediatric community, pediatric intensive care, cardiac anesthesia, who are very good in pediatric anesthesia, I think we've kind of gotten away with this, apprehension about the weight. So at any weight, if there is a reason for an intervention, for example, obstructive TAPVC, you really can't wait, or a TGA intact septum, there is absolutely no criteria for weight. Yes, where you think you can wait in terms of intervention, it is okay to let the baby grow a little bit. But as I said, there is really no minimal weight criteria for any disease now.
So, ma'am, one more thing, as we work with the intensivist in the large VSD, recurrent LRTI concept and then sending for the surgery, like I am closely working with our team of intensivists, and we see large VSD 3-month-old with LRTI. It's difficult to treat LRTI. Now, normally as a peds cardiologist say, you go to the center and treat the LRTI, but it takes 2 months, 1.5 months. So it's a difficult task to treat a VSD with LRTI, and unless peds card is around, in the pediatricians cannot treat these patients because they don't know how to manage the hemodynamics, how to manage the LRTI. So the center is needed where you have ICU care and cardiologist along with to manage a VSD with LRTI. So what I was saying, if you have a early LRTI, you should, most of the time LRTI happens at 3 months of age. So probably we have to go down on the age in large VSD patients where we think this patient may go into LRTI and then they may not come out. I think I don't have data, but I think we are losing a lot of patients because of LRTI in large VSD at 3 months of age.
Actually, Neeraj, there is data from Amrita, published many years ago, where they exactly said what you said, that the LRTI may not go away unless you operate. So they have given data that on ventilator, patient is on ventilator because of LRTI, and patient has undergone VSD closure successfully. So I think the time has come where we say, okay, there should be any active infection as such. The counts are, should be normal. There shouldn't be any fever. But if the LRTI is so bad that patient is not able to come off ventilator, it is okay to go ahead and operate. And I think I've seen days where we used to push them for surgery, and the surgeon will say, I will do a PA band only, because that used to be the minimally invasive surgery. And now the surgeon says, no, I don't want to do PA band. I'm more comfortable with total correction. So I think the surgeons have also moved so much from so-called PA band. Now they are more worried and more scared of doing a band than doing a correction.
Yes.
I mean, I've seen that era. So I think you are absolutely right. There's no point going on and on with an LRTI. We should go ahead and operate once we've given enough trial of medical therapy.
Yes, ma'am. And one more question which I keep getting also, you must also be getting from the students. Suppose a large ASD newborn, they keep sending you that it's a large ASD, that keep treating the ASD also. So what is the message from you that if I tell them if it's a common atrium, don't worry about the ASD. That's what I say. But what is your opinion about this neonatal ASD, ma'am?
See, I'm very glad you brought out that question. I think what is happening now, and I keep telling my residents also, we are treating echocardiography. We are not treating the patient. Patient is carrying an echo report of large ASD. Patient is comfortable. The baby is fine, feeding well, growing well. But the parents are so worried because it says a large ASD. So I think large ASD is something that we need not worry about. We should just look at the patient. There may be a small percentage, as I said, about 5% or 3% of ASDs who may be actually into failure. And those are the babies or those are the infants who may need early surgical closure. Barring those, 95, 98% of them don't need anything to be done at that age. And just having an echo diagnosis of large ASD doesn't mean anything. I always tell them, look at the patient, see how the patient is clinically doing. then decide rather than just treating echocardiography. So I think that is where I believe that echocardiography done a bit of a disservice, that we have stopped using our clinical tools.
Yes, yes, ma'am. And one more thing, as Dr. Maria ma'am is there, a lot of pediatric panelists are also there. Like for the large VSD, when I ask, when I go away from Delhi and go to the peripheries, and I ask you, what is the large age of large VSD closure? The age is 5 years, 7 years, 10 years, still is there in the government colleges, in the peripheral dental services. So somehow we have to push for that message, ma'am. Somehow I don't know how, but the message has to go that age is not 5 years or 6 years.
Right. Absolutely. I think it's too late by then.
Yeah, absolutely. And the common understanding by them is it's okay to wait for 10 kg, 15 kg. Still, as you go away from Delhi NCR and from the metros away, there's a big trouble actually.
Yeah, I think also many of them believe that the VSDs are going to close if you wait. I think we need to again make them understand that large VSDs don't close, practically don't close. So I would, go for some intervention. At least I will send them to a referral center rather than wait.
Dr.
Ma'am,
Meena, sir.
Ma'am,
I have
good
a
morning, ma'am.
Doctor,
Good morning, ma'am. I'm working the government setup and I'm just following you since my residency. I'm working that time I'm working in the worked in the Klauti. Right now I'm working the subdivision. I have the different question for you because you are the one of the time in the pediatric cardiology sector field doing the did the entire life work in the government setup. As since my residency, I am observing the still, despite the too much development in the all health segment or health areas, still in the congenital heart disease treatment is so far away from poor men's or such a middle income persons, because still once we able to diagnose the heart disease, but the regarding the treatment still we are the looking toward the face of the AIMS. Even government build up the lot of the health center, they have the advanced facilities. Even I am as a gastroenterologist, we are the doing the wonderful job in the even the Crohn's disease like that. But in the heart disease regarding still that is so away from the our common man's. So what was the reason where we have the fault as a policy maker?
I think your question is very valid, and we have really discussed it and written. It may not be, something that our resident may be very interested into, but your question is very valid, and I'm absolutely very, very passionate about what you said, and that is why we have actually compiled data. If you read 2018, we have compiled data as to what all is happening in India and what all is required. And there is a huge north-south divide. There's a huge north-south divide. When I compile the data, I realize that 72% of children born in south of India were able to undergo cardiac intervention, as compared to 17%, or I think 22% in the north of India. So there's a huge divide between south and north. And what is the difference? There are multiple centers in south. There are very few centers in north. Having said that, majority of the centers in south are also in private sector. Like in north. In north also, practically all centers other than AIMS or maybe Chandigarh, PGI, they're all in private setup. But for some reason, we are not able to cater to our population as south of India is. So we don't have to compare with the Western data. We can compare with Kerala. We can compare with Tamil Nadu, or even for that matter, Karnataka. Not done so well, but still better than what we have done here. So I think there are 2 or 3 issues over here. One is early diagnosis. And as Neeraj just pointed out, that you go a little away from metro, you go 40 kilometers from Delhi, people think that VSD doesn't need closure before 5 years of age. So one is awareness, which is something that we are working on from the PCSI, and I think you all are working very hard for that from IAP side. The second thing is the literacy status of those states. People are not, now I'm in a private sector, and I realize that people are spending far more money in AIMS than they would spend coming to a private sector. And when I say that, or Gangaram for that matter, why I say that? Because in AIMS, they're coming 10 times, 15 times. They're losing their wages. They're traveling far off distances and still ending up paying 60, 70,000 rupees for a simple surgery. In addition, they may be asked to buy stuff from outside. Like if the drug is not available in a government sector, they'll go outside. On the other hand, at Gangaram or in a private sector, they will probably get surgery done for 3 lakhs of rupees. So overall, if you look at what they lose, it's not very different in private sector and government sector. That's something that people don't understand and people are not willing to understand because, it really doesn't make sense to them. But economically, I think it is more viable for them to, or equally viable to them to come to a private setup also. The third thing is these Ayushman Bharat and all these schemes are very, very low priced for a cardiac setup. For a cardiac surgery, the Ayushman scheme is paying something like 2 lakhs, for a switch maybe 3 lakhs. I don't know exactly the rates, but the amount of money that is required for these is much more. And unfortunately, they have the same rates for government setup and private setup. On the other hand, in a private setup, even my salary comes from what patients pay. In a government setup, you get huge grants from the government to pay the salary. So there are a lot of discrepancies, and I think we've tried to bring it up to the policymakers many a times. With Dr. Paul being in Niti Aayog, I think we've highlighted to him because he is the one who understands it best. But for some reason, we've not been able to do it. And I think that's a failure on our part, and we probably need to work harder.
There is a question from Dr. Gangaram Kundal.
Transmits within a virus too. The virus is
I think he's not able to speak.
and viral mutation starts
Pankaj sir, anything else? Pankaj sir?
virus and uses some.
I think we had an excellent session as always.
Pankaj, just 1 minute. I wanted to come in for a second.
Yes, ma'am.
Ma'am, we have addressed most of the issues. Dr. Shamina asked a very pertinent question, which I myself was wanting to discuss. However, there is one more thing which I see. There is one gap and one scope of, maybe thinking and maybe doing something about it. For example, the neonates I'm talking and the maybe younger infants who often need, that's probably the time when they, need most these interventions and even surgical interventions. So at that time, I see them being placed in the, adult cardiac CTVS ICUs, which I think is just not done. So we need to now start thinking of having, I don't know, in private sector, maybe there is such a provision, but at least in the, I'm talking of our hospital, and I think even in AIMS, do they have separate neonatal or infant post-surgical ICUs? I wanted to just say, because the care is not a miniature adult that they can be seen the same way. They need different people, different mindset, different specialists, and different environment completely. Over.
Yeah,
Regarding the newborn, already we have the very good government scheme regarding Janni Sishu Suraksha Karikram, in which till the 1 year have the insurance about the all the health packages or charges, the baby getting the free of treatment. But issues in the government setup, we have the not a dedicated pediatric cardiologist expert or CTVS surgeon that able to do the surgery or timely intervention. Nowadays, even in the my hospital, Safdarjung, they are starting to doing the surgery, but due to the absence of the dedicated team, our outcome is not very good. Then the mortality already in such a heart disease is very high. So we need the more expertise in the government setup, more advocacy, good policies, all the combined efforts be required.
And I think more accountability.
Yes, ma'am. Yes.
In private setup, you cannot just manage like that. You are accountable for each and every penny that you take from the patient.
Exactly.
For the students, all the students who are listening, mortality rate in a pediatric cardiac surgery unit is less than 2% nowadays. It's not more than 2%, including newborns. So those who are listening and are planning to become a peds cardio in future, they can go ahead. Outcomes are great.
Yeah, nation requires the more pediatric cardiologists.
The surgeons.
Dedicated.
I think we are short of surgeons for sure, but
Yeah.
yes, we can do more. But I think there are multiple, issues that are there, and some of you have highlighted it very well. Aarti has also highlighted that. Just for your information, Aarti, now they have a pediatric ICU which is separate, pediatric cardiac ICU which is separate than adults, and of course they keep putting little older children in the adult ICU also, because AIMS has far more congenital cases than it has adult cases now. Because adult cardiologists have practically taken away their bread and butter by doing angioplasty. So they practically have congenital cases of all ages, including newborns, including older children. And for newborns, they do have a separate ICU. They do have intensivists. So I think that's the need of the day. We cannot deny that. You're absolutely right.
Yeah,
So
and
I
I'm
think,
aware of your
I agree.
pediatric cardiology, of course, ma'am.
Yeah.
Yeah. Thank you. Thank you so much, ma'am.
Thank you.
All, I would like to invite the all participants and all faculties to upcoming North Zone Pedicon as well as Delhi State Pediatric Conference. That brand name is PCNI. That scheduled on 31st August in Lee Meridian Hotel. I request to all participants kindly register as early as possible and join that conference.
Thank you. So we stop the meeting. Dr. Meena, anything else is remaining?
Yes, sir.
So we can stop the meeting. Thank you, ma'am.
Thank you all.
Thank you.
Ma'am, Saxena ma'am. Thank you very
Thank you.
much. And we'll keep listening to you, ma'am. Thank you.
Thank you very much. Thank you.
Thank you.